the reason I phrased it as articular cartilage damage rather than arthritis is because in the knee, very often you'll have focal chondral defects, so it's not a widespread arthritic process to start with, but if one leaves that and doesn't address it, then it can become so. So what are the risk factors for these kind of injuries? Pivoting sports, soccer, basketball. I've had to differentiate between football and soccer because my fellowship was in Canada and football meant something else to them. So previous knee injury, also for example if there's a meniscal injury or ACL injury and they're ACL deficient, that does predispose the knee to episodes of instability and giving way, and that can lead to articular cartilage damage. Certainly one study showed that patients undergoing ACL reconstruction, 50% of them were found to have articular cartilage defects. Similarly, several studies have showed a very high incidence of articular cartilage damage in patients undergoing an arthroscopy. So approximately 60% of patients are found to have at least some degree of articular cartilage damage. So very commonly on the medial femoral condyle. So the other thing to bear in mind is that there can be many associated injuries. So if someone has articular cartilage damage, they can also have a meniscal injury or an ACL injury, and these need to be addressed as well, and it needs to be borne in mind when dealing with such patients. So this is just a brief summary, but basically the essence is that articular cartilage does not have a good vascular supply, and consequently the healing capacity is very limited. So the natural history, because the healing capacity is limited, one doesn't get regeneration of the native articular cartilage, which is hyaline cartilage. You get essentially fibrocartilage, which is cartilage, but it is biomechanically inferior to normal native articular cartilage. So the goal here is basically to recognize and pick up the patients that have articular cartilage injuries, deal with them, institute appropriate management, and allow them to get back to a pre-injury level of function. So how do these patients present? Well, they can often present in terms of just swelling or a sensation of giving way. Now, this giving way needs to be differentiated to some extent from what one will experience with an ACL injury. This is more related to the fact that they can have a loose body, which is getting trapped in the joint, and as this loose body moves, they feel that the knee is sort of giving out on them, and that's what they complain of. Occasionally, if the loose body is trapped between the articular surfaces of the knee, you can get locking and pain. Often this mimics meniscal pathology with joint line pain. So in terms of diagnosis, how does one go about it? We can do x-rays. Plain x-rays is always the starting point for orthopedic investigation. Unfortunately, as cartilage is poorly shown on plain radiographs, very often we don't see anything. So the important issue is to really be able to, on the basis of history and clinical examination, identify the patients that need further investigation. So MRI is the next step, and this will tell us if there is an area of articular cartilage damage. It will often also show some underlying bone bruising to the area that's been injured. Occasionally one may see that there is an area of damage, but the cartilage fragment has not been displaced and is still sitting from where it originated. Arthroscopy is the sort of definitive investigation in terms of the fact that at the time of arthroscopy you really get an opportunity to look at the lesion and assess its depth and size, and subsequent to that be able to decide on the best form of treatment for it. So there are several options in how to go about treating such patients. Again, as with all orthopedic conditions, non-operative has to be one option dependent on patient profile and activity aspirations. Arthroscopic debridement, also called chondroplasty, is sort of next up the ladder. Microfracture, which is a technique popularized by Steadman from the US, is a technique which is appealing to both patients and surgeons in that it is relatively straightforward to do. It doesn't take very long. There are associated problems with the rehab in that patients have to sort of comply with certain restrictions, but overall it's not too demanding. Osteochondral transfer, also known as mosaicplasty, is a little bit more of a sort of technically requiring surgical procedure, and this involves taking pieces of articular cartilage from non-weight-bearing areas and transferring them. Cell-based cartilage repair is basically autologous chondrocyte implantation, which is either done just the chondrocytes themselves, or now what is being taken a step further is matrix associated chondrocyte implantation. So that means you have a scaffold which is used in the lab and the cells are seeded onto that. High tibial osteotomy and a unicompartmental knee replacement are really going one stage beyond the chondral injury, in the sense that this is an indication when the degree of cartilage damage has progressed and is involving the entire compartment of the knee. So non-operative would just involve really activity modification, rest, anti-inflammatories. Injections of either steroids or hyaluronic acid are a little bit controversial, and there's no clear evidence that they really change the natural history of the condition. Non-weight bearing, period of rest, and sometimes if there's associated malalignment, an offloading brace just to help with reducing pain helps. So moving on to chondroplasty. Chondroplasty would be indicated from our perspective if the cartilage defect is relatively superficial and there are loose flaps present, which we can just trim back to a stable margin, help with any sort of impingement that's taking place in the joint. And this is really only for superficial partial thickness articular cartilage defects. Short-term follow-up studies show that basically it's providing good results. So microfracture is a technique which has now been around for some time. The technique in itself is not particularly demanding, in that what it involves is us clearing out the defect, making some holes in the bone and allowing the stem cells from the medulla of the bone to migrate to the area of damage and subsequently form a new layer of cartilage. Thing to note is that, again, the cartilage that forms is not as good as our normal native hyaline cartilage. It is a fibrocartilage, but it's better than not having any cartilage cover, and symptomatically it provides fairly good relief. The problem issue that arises here, however, is the fact that the rehab protocol for this is fairly stringent, in that what Stegman has actually described involves 6 to 8 weeks of non-weight bearing and CPM or repetitions of flexion extension exercises. And that's what he has described in terms of obtaining best results, and his results haven't been replicated. So really that is what one should try and go for. So here is results. Basically 80% of patients consider themselves improved. As just alluded to, other studies have shown that it's slightly less than that. It's still not bad in terms of a good to excellent outcome of 67%. So this is what I was alluding to in terms of the rehab. So moving on to mosaicplasty. This is, as mentioned earlier, basically what we do is we take a core of bone from a non-weight bearing area, core that out, and transfer that into the defect area. So there are limitations. In essence, basically one of the most important ones being the donor site availability. So you know, how much graft can you actually obtain, and that does limit for the size of lesion that this can be used for. So this is just some clinical photographs showing the procedure. So this is the donor site where the cores of bone and articular cartilage have been taken from, and the slide on your left shows where it's been implanted into. So this is an arthroscopic view. I don't know if it projects all that well, but you can just make out. So this is 2 years after surgery, and you can make out that, you know, to a large extent it's incorporated pretty well and it's given a pretty smooth surface. So this is a synthetic bone graft substitute with a articular cartilage-like material on the top. It's called a true fit bone plug, and this is something that can be used instead of the native core of bone and articular cartilage, and something that can be used in adjunct, for example, if we don't obtain enough graft from the knee. So moving on to cell-based techniques, this is basically a process by which we harvest chondrocytes, so take a small sliver of articular cartilage from a non-weight bearing area in the knee, you break it down in the lab with enzymes, and then you culture that up. And once you've expanded, so you've got more chondrocytes, you can then inject that back into the knee. It's really patients who are in the age range of 20 to 50. Isolated femoral condyle lesions have been shown to do best. Plus side, it can be used to tackle fairly large defects, up to 10 square centimeters. Ideally 3 to 6 millimeters deep, but even if they're up to 10 millimeters deep, it is a technique that can be employed. There are a few contraindications. One is if there's malalignment or you've got a so-called kissing lesion, so there's pressure on that area, it's not likely to heal and do well. One of the other problems, relative contraindications faced presently by us, is that it's not fully approved by NICE to be performed in the NHS. What they say is that if you're doing it, it needs to be part of a trial where the patients need to be followed up and monitored on a regular basis. So studies have been done, as mentioned earlier. The younger the patient, they tend to do better. If it's if the defect has not been there for a long time, again, better outcome. Higher pre-op knee scores. Most of these are fairly sort of self-explanatory in the sense if your knee's better to start with, it's better after the surgery. And single defects and basically trochlear femoral condyle defects. So this is an MRI scan that shows the area. So this is to start with as the focal condyle defect, which is the white patch on the femoral condyle. Here you can just make it out. This is a year after the procedure. You can just make it out, but you can tell that basically it is improved and there's less of a defect present. So this is just really to complete the topic in the sense that we're now moving on from arthroscopic procedures to open procedures, and if we're dealing with articular cartilage damage to the whole compartment, then arthroscopic procedures are no longer satisfactory, and we need to be looking at a high tibial osteotomy or unicondylar knee replacement. Again, recent publications from this year have shown very good interest. The high tibial osteotomy is also showing over 80% good results. So, just to summarize the sort of management scheme, I don't think the top part is projected, but basically far left should say superficial, so if it's a superficial defect, then chondroplasty is your option. If it's a small defect, basically 2 to 4 square centimeters, then you can look at microfracture, mosaicplasty or ACI. Larger defects, 4 to 10 square centimeters, we're looking at mosaicplasty augmented with a true fit plug, and possibly the chondrocyte implantation as well. And finally, if it's involving the entire compartment, it's a high tibial osteotomy or a unicompartmental knee replacement. So, in conclusion, this is a common problem, but it's difficult to diagnose accurately, and you need to have high index of suspicion. And if the history and examination suggest it, then one should investigate further by way of MRI. We do have several treatment options available, and those need to be tailored according to the presentation of the patient, their age, activity profile, and what they're really looking to get back to. Treatment is based on the size and depth of the lesion, and that's all. Thank you very much.
Thank you.